Good afternoon, everyone. I am Christina Talbert-Slagle, Assistant Professor at the Yale School of Medicine and Director of the Faculty Support Initiative at the Yale Institute for Global Health. I am also the Principal Investigator for Applying Research for a Healthy Liberia, a 5-year collaborative project with the University of Liberia College of Health Sciences and Vanderbilt University, funded by the U.S. Agency for International Development. I am delighted to welcome you to this Global Health Conversation Series event, Ebola, 10 Years On, Reflections and Lessons Learned. In addition to the Yale Institute for Global Health, or YIGH, today's event is co-sponsored by the Walker Fund and the Council on African Studies at the Macmillan Center at Yale. This December marks the 10-year anniversary of the emergence of Ebola in the West African country of Guinea, an event that caused a tragic epidemic and more than 10,000 deaths in Guinea and its neighboring countries, Liberia and Sierra Leone. Since the 2013-15 Ebola epidemic, the world has experienced numerous global health threats, such as further Ebola outbreaks, Marburg, measles, and COVID-19, among others. During this webinar, 3 senior health leaders who responded to the Ebola epidemic in Liberia, Guinea, and Sierra Leone will share their reflections on the weaknesses in healthcare, public health, and health financing that exacerbated the Ebola crisis in their countries, as well as lessons learned that can be or have already been applied to respond better to emerging infectious disease threats, build more resilient health systems, and improve health outcomes globally. It is our pleasure to have 3 distinguished guests joining us today, all of whom are esteemed leaders in global public health. To formally introduce our panelists, I will now turn to my colleague, Dr. Sabine Franklin.
Hello, everyone. My name is Dr. Sabine Franklin, and I am a Mellon Postdoctoral Fellow in the Africana Studies Department at Wellesley College. It is my pleasure to introduce our distinguished panel and to moderate today's event. Dr. Bernice Dawn was the Minister of Health of Liberia from 2015 to 2018, and previously served as the Chief Medical Officer of Liberia from 2006 to 2015, where she oversaw post-war health system strengthening efforts. She is currently the Vice President for Health Sciences at the University of Liberia, leading the College of Sciences, which houses the only schools of medicine and pharmacy in the country, as well as the new School of Public Health and Nursing Midwifery program. Dr. Dawn has authored more than 40 publications, spearheaded an investment plan for building a resilient health system in Liberia post-Ebola, and is internationally recognized expert in health system strengthening and pandemic recovery. Dr. Sila Thiam is a public health specialist with more than 20 years experience in health management and leadership across Africa. He is currently an independent consultant and a part-time research associate at the University of Thiès in Senegal. He has been with Amref Health Africa, the largest healthcare nonprofit on the continent, from 2011 until 2018, when he was the regional director of Amref in West Africa. Prior to that, he worked with the Ministry of Health in Senegal in various positions at district and national levels, leading various campaigns, notably the reduction of the malaria cases via systemic changes to the ministry's surveillance and delivery of services. Paramount Chief David Mandu Farley Kylie Kumber IV is an experienced engineer who spent 2 decades in the United States before returning to Sierra Leone in 2008 to work in the mining sector. He was elected to head the Mandu chiefdom in the Kalahoun district on December 2nd, 2013. A few weeks later, the first case of the Ebola virus disease in a child occurred in the Gwekodo Prefecture in Guinea, which borders the Kalahoun district, and it ultimately caused the child's death and triggered the 2013 to 2016 pandemic. Thus, one of his first governance challenge was to implement emergency bylaws. He convinced other paramount chiefs in the Calahoun district to implement the same bylaws to discourage movement, close contact, and encourage health-seeking behaviors. These were later scaled up and implemented as part of Sierra Leone's National Emergency Declaration in August 2014. So welcome to all of our panelists. It is great to have you here with us today. So we are moving now to the first round, and I ask each panelist this question. It has been 10 years and tens of thousands of articles, photos, and reports on the deadliest outbreak of the Ebola virus disease. What parts of the narrative or the story is missing? And can you tell us that story in 2 minutes? I will start with Dr. Don.
Thank you, and hello to everyone who is on to listen. It's 10 years after the outbreak, and during the outbreak, there was this momentum to build resilient healthcare delivery systems to ensure that the impact of outbreaks will not be felt like the way it was felt during the Ebola outbreak for countries. And countries should be better prepared for new emergencies. Which part of the story that is not being told? There was momentum to support countries, strengthen countries along building the resilient healthcare delivery systems. Countries supported countries that were weak to help them build the resilient healthcare delivery systems. Promises were made. Some of those promises were not fulfilled. Not every promise that was made was a new promise. And moving onwards, whether countries still align to the efforts of building the resilience that we all felt should have been built with the outbreak of the disease of Ebola and moving on. So for me, I will summarize that to that and wait for the next question. Thank you.
Thank you, Dr. Don. So we'll move on to Dr. Thiam. Could you please tell us what parts of the story or the narrative is missing in 2 minutes?
OK. Pour moi, la partie de l'histoire qui manque, c'est cette histoire de l'infirmier qui est dans la zone périphérique, qui fait face à une épidémie. L'infirmier ou le médecin qui fait face à une épidémie, qui est en zone reculée, et qui doit faire face à 3 dilemmes. Le premier dilemme, c'est qu'il ne doit pas abandonner le poste parce qu'il est l'espoir de centaines de personnes. Et ces personnes dépendent de lui. Le deuxième dilemme, c'est que cette personne il brave la mort tous les jours, mais il ne doit pas se faire contaminer. Il ne doit pas mourir, mais il doit également protéger sa famille. Il ne doit pas mourir parce qu'il est l'espoir de ces personnes dans la communauté qui espèrent sur lui pour être sauvés, mais également, il ne doit pas mourir parce qu'il est le pilier de sa famille. Et ce pilier-là ne doit pas mourir. Et force de ça, en marge de cela, il doit faire face aux sollicitations, aux récriminations, aux violences, parfois verbales et rarement physiques. Et dernièrement, c'est cette personne-là, cet agent au niveau périphérique qui reçoit toutes les directives, tous les messages, et il doit les transmettre à la population. Mais ce qu'il faut voir, c'est que dans le contexte ouest-africain, avec une pluralité des langues, il doit traduire tous ces messages, toutes ces directives et les véhiculer dans les langues locales. Voilà cette partie-là qui n'a pas été très bien racontée à mon sens. Merci.
Paramount Chief Farley, could you tell us what part of the narratives or the story is missing? And could you please tell us that in 2 minutes?
two issues. There are many, but two principal issues. One is how important the governance structure, governance issues are to properly address emerging diseases, and specifically a problem like Ebola. I can give examples of that later on. That's the first issue. The second issue is that in terms of local populations, Ebola was a very severe crisis, but keeping it in perspective, there are still normal diseases that are endemic here that kill so many more people long after the international efforts have been very well appreciated. International efforts were made to combat Ebola. I'm talking specifically about malaria and typhoid, which continues, unfortunately, to take a very high mortality toll on our regular populations. And so while we're very happy about the attention that was brought to our healthcare issues by the Ebola epidemic, there's an ongoing endemic of regular diseases that need to be addressed and that the population will want people like me to keep talking about.
All right, thank you, Paramount Chief Farley. And so we'll bring it back to Dr. Don. What was the most significant challenge you faced during the Ebola crisis in your country, and how did you respond?
Initially, coordinating donor partners to align to and respond to the emergency was challenging. We had an emergency and everyone was willing to help. So we had a lot of influx of partners, both donors and implementing partners, coming in to help. We were having coordination meetings, but from the initial stages, those coordination meetings were not very efficient. And so partners were like parachuting, going and doing things on their own until we were able to regroup, design a system that brought in the incident management system, established emergency operations centers, mapped out the partners and divided them geographically to support specific things within the counties and help to build the county health capacity before we were able to get it straight.
Okay, thank you, Dr. Don. And Dr. Thiam, what was the most significant challenge you faced during the Ebola crisis when you were in Guinea, and how did you respond?
En tant qu'organisation africaine internationale, le défi que nous avions, c'est qu'on était dans un contexte de multiplicité et de diversité des intervenants, dans un contexte de réticence de la population et de manque de coordination de toutes les actions, de faiblesse de coordination. Il y avait une coordination qui était très faible. Et pour nous, c'était de voir quelle était la meilleure, comment apporter une contribution significative dans ce contexte. Et le défi principal à l'époque, c'était en Guinée, il y avait une réticence de la population qui rejetait la plupart des mesures de prévention et de prise en charge. Et à cette époque, il y avait même une militarisation de la riposte. Et nous, ce que nous avons fait en tant qu'ABREF, c'est qu'on s'est concentré dans les zones où il y avait une forte transmission, une forte réticence, et on a fait une analyse de la situation. On a fait une analyse de la situation et on a utilisé notre force qui est quoi? Le système communautaire en renforçant les ponts entre le système de santé formel et le système communautaire. Et nous sommes allés au niveau communautaire et on a pris de nouveaux acteurs. Parce que les anciens acteurs qui étaient constitués par les agents de santé communautaires étaient ceux qui étaient utilisés au niveau communautaire. Et ces agents étaient animés au poste de santé, mais avec le manque de confiance, ces agents étaient disqualifiés. Donc, nous avons utilisé les organisations communautaires de base pour pouvoir les capaciter et ensuite les utiliser dans la prévention, dans la communication, et nous avons renforcé les formations sanitaires périphériques et nous avons créé une coordination locale entre les communautés et les structures de santé périphériques. Et ça a beaucoup amélioré l'adhésion des populations aux directives et ça a diminué la réticence.
Thank you, Dr. Thiam. And Paramount Chief Farley, what would you say was the most significant challenge that you faced during Ebola in Sierra Leone?
Okay, there are several issues, but I think they all center around the fact that Ebola was the first really major modern health crisis that the country had experienced. And so the first thing was the very negative reaction of our local communities. We were a little bit fortunate that it started in the rural areas. And by the time it had gotten to the urban areas, the situation was still bad, but at least the government had had some experience with what was happening. But the major issue there was a stigma associated with the disease. When a community suddenly starts seeing there are several members of their community going to hospital and dying consistently, and when they saw ambulances coming into the community, they will usually the youth will gather up and throw stones at the ambulances and not even accept those health initiatives. Also, because of the stigma associated with the disease and high fatality that was involved in the disease, because of our very poor healthcare system. When you had Ebola, it was basically a sentence of death. And so people used to hide the fact that they had Ebola at all. And that obviously helped in its transmission. There was also the issue of people wanting our culture dictates that we have a very caring community. Usually people usually visit sick people, and especially when somebody dies, a large number of people in communities usually attend to that person. And obviously, in the case of Ebola, people who got in contact with somebody who even died from Ebola or got sick from Ebola will easily get the disease. So it became an almost a hopeless situation where if they say you have Ebola, or if somebody got sick, he will hide the fact that he was sick, even if he or she was just sick with malaria or typhoid or some really perfectly curable disease. They will deny that they have that disease because once they were told, the authorities knew that they had Ebola, they'll be taken to an Ebola center where they will invariably never return. It got a little bit better as time went on when we had better facilities.
Sorry, Paramount Chief Farley, I have to interrupt. You got 10 seconds left.
Okay, it got a little bit better, but that was the main issue that we had to deal with. Then, of course, we had to deal with the poor governance structure that we have, but I'll address that later on.
Okay, thank you, Paramount Chief Farley. So we're moving on to the next round where each panelist will have 1 minute to respond. So if a panelist is responding and another panelist likes the points that they made, they can raise 2 fingers, such as I'm demonstrating, and they can add on to that person's point for 20 seconds. Or if you can raise a full hand to object, if you want to give a dissenting view, you'll have 30 seconds to give that view. And then the original panelists will have 30 seconds to respond to that view. And yes, I am timing it on my timer. So we will begin with Dr. Don. You also have the unique experience of working inside a Ministry of Health. And what do you feel were the challenges of integrating those NGO resources in a government response, and how can that be improved?
Is the question related to the Ebola or just the overall?
It's related to Ebola for now.
Okay. Okay, so yes, thank you. The normally partners, both donor partners and implementing partners will stress accountability, efficiency, and accountability. Working with the government, you'll realize that accountability is a one-way street. Okay, so I was saying, normally within global health, we all stress accountability and efficiency, effectiveness and efficiency. When you work in the government, you realize that accountability is a one-way street. Donor partners tend to hold governments accountable for resources that are provided for them from their countries. But the country, the recipient, does not have the same opportunity to ask for accountability in the other direction. So you will realize that, for example, a donor gives an NGO maybe $10 million.
Dr. Don, could you wrap up the example in just 10 seconds, please?
Okay, a donor gives an NGO $10 million to support services. You ask for detailed services, a detailed breakdown of that budget, it is difficult to get. And so it becomes difficult to align those that resource to resources that you already have to be able to complement one another. Thank you.
Thank you, Dr. Don. And for Paramount Chief Farley, can you please tell us about the interactions between emergency responders and the local communities, such as the burial teams, healthcare workers that you had mentioned earlier?
It started out really bad. As I said, the first time I actually noticed that there was a problem with in the country, or at least in our region, was we had just come back from a meeting of Paramount Chief, and I was traveling through a chiefdom that was neighboring to my own chiefdom at night, and I saw.
Farley, we're having a trouble hearing you. If you could speak a little louder, please. We're having a little trouble hearing you. Thank you.
All right. And I said the first time I noticed that we had a problem in the country was when we were traveling from a meeting of Paramount Chiefs in Kailan district, and at night, and I saw a huge crowd on the roadside attacking an ambulance. And I had to come down and I asked what was going on. I found out that they said the ambulance people had said they had brought in a corpse who died from a new disease, and that there were other instructions not to let the people handle that corpse. And so there was a huge hue and cry about that. But that was the start. But then, unfortunately, or maybe, I don't know, providentially, in that same chiefdom, not very long after that, the wife of the Paramount Chief died. And so there was a much better thrust of wanting to handle this issue together, so that by the end of the epidemic, there was a very, very good relationship between the community, the medical care providers, and the traditional leaders like us. So it started out very badly, but over a period of time, we ended up with a fairly good relationship, and it's a good lesson that we'll learn for future interventions.
All right, thank you. Dr. Dawn, can we go back for you to finish your thought, please, in terms of, so what were the, I'm sorry. So the original question were, what were the challenges of integrating those NGO resources into the government response and how these can be improved? So you left off at accountability.
Yes. So I was saying it is difficult to, especially for implementing partners, to share detailed budgets. And so aligning those budgets to what you already have, resources that you have, to ensure that they complement one another is difficult. Take, for example, quite recently, there was an RFA. We decided to join with an NGO partner to apply. The RFA, one of the terms is to strengthen local health systems. And so local, in that RFA, 50% of the budget should go to local institutions. The international partner was the one priming. We agreed to that. They broke down the budget and gave us about 5.4 out of $24 million for over 5 years. We did a detailed budget for our portion of the $24 million, which is the 5.4. But we just couldn't get them to give us the details, and we were partners on the table designing a project. And that is even, it's not the only one, but it's been happening. I've noticed a difference with training institutions and also the health sector. Most US universities, for example, will tell you our overhead is 25%, 35%. So you know that, and when you are designing the project, you take that into consideration. But all the US NGOs will not tell you what their overhead is. It's not negotiated with the government. It's outside of it. So you really don't know what their overhead is. And then at the end of the day, you realize that what actually goes to the project is by far less than what it is. And that has implications for government, because when you sign a $50 million project, for example, in Liberia, Liberians want to see $50 million worth of projects in terms of implementation. And so when they don't see that, they feel that the money has been sold, government is abusing the money and things like that. But many times those monies don't even come to the country. A good portion of it don't even come to the country. And you really don't see how much to really say this is the amount that actually went to program and services, and this went into overheads for others. And that I've seen the difference also with some of the US training institutions, that they will be transparent and you all work the budget together, as compared to the NGO partners that you really don't know how it goes. Thank you.
Thank you, Dr. Dawn. I see Paramount Chief Farley has 2 fingers up. So please add on, you have 20 seconds.
Yes, I'll just add that there's an accountability issue also on the part of our national governments. I govern a local government, a traditional local government that used to exist even before the colonial era. And our people implicitly trust their paramount chiefs significantly, much more so than central government. But even when we get donations to our central governments, very little of it triggers into our local communities, into chiefdoms like we have, for instance. And so it's a double whammy. Dr. Dean has a problem with accountability from NGOs. We have a problem, but NGOs still give a little bit to the central government. But even that little bit, the central government, they give the central government, does not get to the communities which actually get to implement things that actually address the diseases, the problems we have in our communities. So I just wanted to buttress that.
Thank you, Paramount Chief Farley. And to follow up finally with the Dr. Thiam. So you also have the unique experience of working inside the Ministry of Health and then working for a major health NGO, AMREF. So what do you feel are the challenges of integrating NGO resources in this type of government coordinated response? How can that be improved?
Oui, le problème c'est que, en fait, le problème, c'est que c'est l'ensemble de ces ressources sont des ressources externes. Et on voit que la plupart de nos activités sont financées par des donateurs externes avec des conditions et des orientations qui sont parfois non adaptées au contexte du pays. Et comme l'a dit tout à l'heure le docteur Dan, c'est qu'il y a un problème de coordination, il y a un problème parfois de transparence. Et nous pensons qu'il est important que les États africains doivent promouvoir l'essor d'une société civile forte et renforcer les ONG locales et leur donner des financements en matière de santé. Ça, c'est important parce que je pense que le docteur Dan l'a dit. Donc, il y a ce problème-là de transparence, de coordination, mais également de voir les ressources aller jusqu'au niveau de la communauté. Ça, c'est parfois un grand problème. Mais l'autre problème qu'on a remarqué également, et ça dans le cadre de la COVID, je pense qu'il y a une dynamique au niveau des pays pour renforcer la mobilisation des ressources au niveau domestique. Et on l'a vu avec la COVID, par rapport à Ebola où les ressources étaient plus externes. Dans le cadre de la COVID, la plupart des pays, les ressources ont changé. Donc, les ONG ont apporté, mais les pays ont également apporté, donc à travers le secteur privé et les ONG locales et les mécènes.
Thank you, Dr. Hyam. And thinking now, going back to the very beginning of the Ebola epidemic and the misconceptions around it, such as stigma, local culture or customs, or the involvement of local communities in some regions. As a result, distrust developed between those communities and those seeking to control the epidemic. So after working in these different regions in your position as regional director of AMREF, what have you learned and how can we prevent mistrust between communities and public health responders?
Pour moi, il y a 7 éléments qu'il faut considérer. 7 éléments dont les 2 ou 3 premiers sont très importants. Donc, il ne faut pas juger. Il faut essayer de comprendre d'abord les études et les pratiques de communauté sans juger. Ne pas avoir un complexe de supériorité parce que c'est ça un peu le problème qu'on a vécu avec Ebola. Donc, les gens sont venus avec des mesures et pensent que c'est ça qu'il faut. Et sans comprendre un peu comment les populations interprètent et voient ces directives-là. Ne pas éviter d'être un donneur de leçons. Donc, il faut comprendre. La deuxième chose, c'est avoir un langage de vérité en toutes circonstances et éviter les manipulations. Troisième chose, limiter l'action politique. C'est-à-dire qu'il ne faut pas qu'il y ait... Parce que la logique des acteurs politiques est différente de la logique des techniciens. Donc, il faut que l'action politique ne parasite pas la réponse sanitaire. Parce qu'on l'a vu, par exemple, dans le cadre de COVID, au Sénégal, on a vu qu'il y avait une bonne dynamique dans la lutte. Mais dès qu'il y a eu une interférence avec l'action politique qui a voulu profiter de la situation pour distribuer des nourritures et autres, il y a une déviation qui a fait que les gens n'ont plus adhéré aux mesures. Quatrième chose, il est important d'impliquer la communauté dans la planification et la mise en œuvre des interventions, car c'est ça le gage certain de leur adhésion aux mesures de contrôle de l'épidémie. Cinquième élément, c'est de créer des cadres de concertation entre le personnel et la communauté, que ce soit les élus locaux, les leaders communautaires, les organisations communautaires de base, pour renforcer la redevabilité des structures sanitaires envers la communauté et mettre fin ainsi aux rumeurs et aux méfiances. Sixième élément, il est important que les formations sanitaires soient renforcer donc, les soins de santé primaires pour améliorer la qualité des services. Ceci renforcera la confiance entre la communauté et les structures sanitaires. Et dernière chose, c'est renforcer les capacités des acteurs communautaires et du leadership local. Je suis très content de partager ce panel avec le chief parce qu'ils ont un rôle important à jouer. Et ils doivent être la porte d'entrée avec le système de santé. Et ces éléments doivent être pris en compte dans les stratégies nationales parce que ça renforce l'autonomisation de la communauté et ça les pousse à être coproductrices et coprotectrices de leur propre santé. Merci.
Thank you, Dr. Thiam. And Paramount Chief Farley, thinking about the international responses, for example, MSF or Western governments that are often put in the spotlight when dealing with a global health crisis such as Ebola, how has your work with other Paramount Chief demonstrates that local communities are capable of meeting these challenges? So how can international organizations or other governments better support local communities to address future emergencies?
Deal with Paramount Chiefs directly. Most of our communities have traditional governance structures that the communities trust a whole lot more than the national government. Most of our national governments are essentially inheritors of a mantle of the colonial authorities. And unfortunately, in a lot of African countries, especially in the rural areas or in the vast majority of the country, the people in governance in our major, at the national level, basically take an attitude of a colonialist towards the rural areas. And so, like in Sierra Leone, things are very highly centralized. Most of our traditional structures have been weakened significantly. And since our productive capacity has been reduced also significantly, to a large extent, we depend to a large extent on funds coming in from outside. Now, a lot of these funds go directly to the government, but a lot of it also goes to NGOs. None of it goes to Paramount Chiefs and local leaders directly. And yet, we are the people that people trust more than anybody else to deliver the care that they need. So my suggestion, one way we could think about it is obviously get our NGOs very accountable, but also have them give them instructions and find a way to monitor whether they have had direct relationships with traditional leaders of those communities. And there are all sorts of ways that we could structure that. But on a broad basis, I think that probably is the best way to go. International countries or organizations and NGOs, when they come, yes, you need some permission from the government to operate, but make sure that most of your resources are directed towards direct interactions with your traditional leaders, whom the communities respond to a lot better and who are a lot more accountable to the communities.
Thank you, Paramount Chief Farley. And Dr. Don, we want to wrap up this section. Can you please tell us about the lessons learned from Liberia's experience with Ebola and how that could have been informed for this current or recent outbreak with COVID?
Thank you. The systems we put in place for the Ebola outbreak help us with the COVID outbreak. It was during the Ebola time that we established the IMS, Emergency Management System, the Incident Management System, and then established the EOCs in the 15 counties, Emergency Operations Centers. We also put in place a full surveillance system from community-based event reporting to real disease surveillance, active surveillance system within the communities, all the way to the central level that is reported within 24, 48 hours. So those systems, the IMS is normally activated when there is an outbreak. And then after the outbreak, the EOCs continue to function within the counties because we will always have some outbreaks that we can manage normally. Measles outbreak, for example, yellow fever, those things continue. So the EOC continue to function at the county level. So with the outbreak of the COVID, the IMS was reactivated quickly. All the EOCs were there functional, and so we were able to intervene quickly. Now, we also had a few challenges with that also. The central level, which is the IMS system, we established during after the Ebola, we established the National Public Health Institute. And the institute is responsible for disease surveillance and emergency response. The definition of that emergency response, because we know that at some point, the routine health services had to come in place, especially for case management within the emergency system. So there was this struggle between the central ministry and the National Public Health Institute as to who provides the leadership for the COVID response. But fortunately for us, at the decentralized level, the EOCs were functional. So they were able to intervene quickly. And then WHO actually supported those of us who were in country and had the experience of managing the emergency to work at the decentralized level, some of us, especially where we had the outbreaks, to be able to curtail the disease. So the system actually helped us, and then the impact was not as much as we saw in other countries.
Okay, thank you, Dr. Don. So we want to move to this last round before we open it up for Q&A, to give the panelists a chance to respond to the same question. So each panelist, again, will have 60 seconds to respond. You can raise 2 fingers to agree and add on for 20 seconds, or a full hand to dissent and then add on for 30 seconds. And then the original panel member will have 30 seconds to respond. So, how can universal access to primary care, healthcare in low-income countries improve global health security? What do donors and Western-based agencies need to hear? We'll start with Dr. Thiam. Dr. Thiam, you're on mute.
Oh, okay, not me, right?
Oh, no, Dr. Thiam.
Okay. Pour moi, c'est important qu'on fasse un changement de paradigme, parce que nos systèmes de santé sont extravertis et ne peuvent pas prospérer à ce rythme, où les priorités et les financements viennent de l'extérieur. Et ça, tant qu'on est dans cette dynamique-là, on ne pourra pas, parce que tous ces financements sont structurés autour de conditions et de priorités qui ne sont pas parfois les priorités de la communauté. Et les financements, c'est des dons donc, et des prêts. Donc, qui sont parfois des prêts. Et on a vu avec la COVID, il y a eu beaucoup de prêts, beaucoup de pays se sont endettés pour faire face à la COVID. Donc, à travers la Banque mondiale ou d'autres institutions de financement. Et parallèlement, il y a d'autres structures ou bien d'autres programmes prioritaires qui n'ont pas pu bénéficier de ce niveau de financement-là. Et c'est des priorités. Donc, pour me résumer, je pense que c'est important que nous fassions ce changement de paradigme pour voir comment financer la santé en fonction de nos besoins, en fonction de nos priorités. Merci.
All right. Thank you, Dr. Thiam. Paramount Chief Farley. Thank
you. First of all, we have to realize that we live in a much smaller world now than in the past. Some diseases aren't quite as infectious as others, but they are nevertheless endemic to the local communities. But if a community is used to having very poor health care to even take care of malaria and typhoid and things like that, which a lot of people still die of, not because they don't know what the diseases is, but it gets to a point where they have to choose between buying food to eat or buying medicine, and invariably they'll buy food or keep buying food until the disease gets so chronic that it becomes incurable. Now, if you have a community that is inured to something like that, when you actually have something that can be transmitted that becomes a threat to Western nations like Ebola, people don't take it very seriously because they already die every day. And so they have a very low expectation of healthcare delivery, and therefore they are not very responsive to diseases that the West will take a lot more. I'll give you an example, like in the case of COVID, I'll tell you that I don't know by what miracle COVID wasn't quite as infectious around here as it was in the West. But if it were, it would have killed a whole lot more people than Ebola. But it's the same phenomenon that people have been used to having very low expectation of a healthcare delivery system. And so when infectious diseases come that could affect the West because of the travel, the ease of travel around the world, that becomes a threat. So we all have an interest in improving that primary healthcare within our communities. And my final point is, whatever you do, start at the local governance level. A lot of it at the national level never trickles down there. But I think I'll talk about it more down the line.
Okay. Thank you, Paramount Chief Farley. Dr. Don?
Okay, thank you. I will start by saying weak systems will continue to remain weak if the systems are not invested in. The first place is the government. Often we all look up to the national government to invest in building systems. Now, when you look at the government's budget, if you take Liberia, for example, that is a low-income country and resources are challenging, you will realize that about 70 to 80% of the budget allocated to the health sector actually goes towards payment of salaries to personnel. Now, the salaries also have challenges. There are salaries that cannot meet the needs of the people who are doing the work. So that's the first thing. Then you are left with 20 to 30% of the amount to build all the systems that need to be in place, especially at the decentralized level where the actual services are being delivered. That tells you that to do that, it will be difficult. Now, many times we have partners who are willing to invest in helping, but they also tend to look at, before they invest and give the government the funding to to implement. They will complain about the weak system. Then they prefer to give the money to NGOs to implement. And so the government system is never built. Now, NGOs will implement, and when the funding is finished, they withdraw. When they withdraw, the work is left back for the government to take on, and the system is not there to take it on. So it's a virtual cycle. Now, within the NGO community too, there are international communities and international NGOs, and there are local NGOs. Normally, the international NGOs are stronger than the local NGOs. So most of the time, the funding also goes to the international NGOs. And then when they have the funding, they recruit from within the system, often the government system, to do the work. So, and then they pay better. So then the government system is being depleted further. So the system is never really built for the government to be able to take charge of the system. Now, government too has its own problems. We have had an opportunity to move from one government to another government. And you will realize that some partners have helped to build some systems. If you take the financial management system, for example, for Liberia, the Union Ministry of Health, during the previous administration, we had donor partners that helped us to put in systems for financial management, procurement, and the internal audit and the rest of it. Those systems function to a good extent. When you change government and another government comes in, then the other government, instead of looking at the system, the new government looking at the system that existed and build on it, they start to do something else new altogether. And so what was started before never get to continue, and then the system continue to be weak. So it's both ways, and that needs to be looked into carefully. The governments themselves, maybe they don't, I don't know whether they understand building a regular system is more political driven than actual technical work. And so we continue to have this vicious cycle of growing small and taking like 3 steps in front and 10 steps backwards once you change government. And so there's a need to also really look at that. The government systems need to be built properly. Government and partners work together to build a system so that it will be sustainable. Thank you.
Thank you, Dr. Don. And I see 2 fingers, first from Paramount Chief Farley and then Dr. Thiam. Chief Farley, yes.
Just a quick point to buttress what Dr. Dan has said, and a solution to what the problem that's of changing the whole system at national level whenever you have a change of government. Because most of these political leaders at national level we don't have a merit system that exists like in the US. When you have a change of governments, all of the leaderships and even a lot of the civil service gets changed because they are looking for rewards for their political supporters. But the good side is in our traditional leadership system, like in Sierra Leone, as much as people criticize it, our people respect chieftaincy. I'm never going to have to stand an election for the rest of my life because our people trust that their paramount chief is going to look after their interests for the rest of their lives. So on the other hand, I'm a lot more accountable to my people, and I'm just giving myself as an example. But generally, our traditional governance system is a lot more stable. Otherwise, our country will have gone to pots. So it's not all hopeless. Even though there's a lot of churning at the national level, there's a lot of stability also at local level. So it's good. It'll be good to try to leverage that.
Thank you, Paramount Chief Farley. Dr. Thiam?
Oui, juste dire que, en fait, je pense que Dr. Dan a bien campé le débat, a bien décrit dessus. Je veux juste apporter une chose sur le manque de continuité et peut-être la dispersion des ressources. La plupart des partenaires extérieurs actuellement sont très enclins à financer les activités communautaires, avoir des agents de santé communautaires, soigner le paludisme, etc. C'est très bien. Donc, on a des acteurs, c'est très bien. Mais vous voyez, on est dans une étape en Afrique où on utilisait les agents de santé communautaire parce qu'on avait un déficit de ressources humaines. Mais actuellement, dans la plupart des pays, vous allez voir qu'on a formé beaucoup d'infirmiers et de sages-femmes qui sont en chômage. Donc, la réflexion serait été de dire, OK, comment nous, on peut utiliser ces acteurs formés pour renforcer le système communautaire au lieu d'utiliser de plus en plus des agents communautaires. Donc, voilà un peu ce type de distorsion également, ou bien de paradigme shift qu'on doit faire pour pouvoir changer les choses. Merci.
Okay. Thank you, Dr. Thiam. And our last question for this round before we move on to Q&A, would it be fair to say that the lack of universal primary health care is in itself a public health emergency? Dr. Don?
Yes. The emergency systems are normally built on the routine healthcare systems. And most of our people seek healthcare at the primary level. The primary level normally is weak because one of the panelists earlier said our governments and the systems are highly centralized. So you will realize that most of the improvement that is done at the central level. Is not. If you take hospitals, for example, you realize that our tertiary hospital, if you come to Liberia, we have like 2 tertiary hospitals. The biggest one is in Monrovia. And what that brings to mind is the focus and the budget that is given to that is by far higher than what goes to primary healthcare level. And what that brings to mind is politicians will think about themselves when they are ill, where they want to go. And so they tend to invest in that more at the expense of the primary healthcare, where the majority of the people who voted for them do seek healthcare. Of course, so when the primary healthcare level is not strong enough, when there's an epidemic can actually and overwhelm the whole country. So the system needs to be considered as a whole and not heavily weighed towards the elite, which is what is happening in most of our countries. Thank you.
All right, thank you, Dr. Don. It is 1:02, and I want to get to the Q&A section because we have so much engagement from the audience. So Paramount Chief Farley and Dr. Thiam, could you please keep your response brief?
Oh yeah.
Paramount Chief Farley?
Primary health. We don't have much of a primary health care to start with because the components that go into delivering primary health care. We have one of those components that we have nurses and auxiliary health workers and even community health officials. Most people know how to diagnose diseases, but that's not the real problem. When you go there, you inevitably they are going to inevitably ask for money that our people don't have to buy medicines, and some of them actually ask for consultations, and so most people just don't get primary health care. even though on paper you have all of these community health offices built, health centers built, but if you don't have money, which most of our rural people don't have, then they don't go there. And so you have these auxiliary units coming in, and it's very dysfunctional. So we don't have much of a primary health care. And yes, that is endemic. That is an epidemic, because as I said, yeah. So that's the point I wanted to make. So.
Thank you, Paramount Chief Farley. And Dr. Thiam?
Les soins de santé primaire, ils sont très importants parce que c'est elles qui permettent en fait la promotion et la prévention à la base, et également les soins curatifs à la base. Et depuis plusieurs années, ces soins sont négligés. Donc, il y a des investissements, mais les investissements ne sont pas faits de manière structurée pour permettre de renforcer le système, les soins de santé primaire, où la majorité, comme l'a dit le docteur Don, la majorité de la population doit être vue. Et ce qui fait que actuellement, on assiste dans les pays au fait que la faiblesse des soins de santé primaire fait que la plupart des patients sautent ces structures périphériques et vont directement dans les hôpitaux qui sont congestionnés. Il y a un rush et les hôpitaux sont dépassés parce qu'ils ne peuvent plus contenir ce rush. Et enfin, il est important de savoir que les financements de la santé doivent aller dans nos pays, principalement dans les soins de santé primaire, et ça doit être accompagné par un système de CMI, de couverture maladie universelle, pour avoir une protection sociale et réduire les coûts indirects des ménages pour la santé.
Okay, thank you, Dr. Thiam. So now I'm looking through the chat and seeing the questions that were sent to me from the audience. I see this first one here is directed to Dr. Don. From your experience as the former Minister of Health in Liberia, how can international funding be structured to not only address immediate health crises, but also contribute to the establishment of enduring healthcare systems? Are there successful models or examples where INGOs have played a pivotal role building long-term healthcare infrastructure in collaboration with local entities?
Okay, thank you. Yes. As a country, the first thing is to provide the directions for the country and for those who want to help you. So countries normally will develop strategic plans and policies to provide directions for the country. Take, for instance, the health sector policy strategy on where you want to take the health sector over a period of time, maybe 5 to 10 years. Now, implementing the policy and the strategy is another thing, because many times people develop policy strategies and it's a document and it is sitting and accumulating dust. So working with especially the decentralized level where the implementation is actually done, normally we do an operational plan, which is annual. And in doing that operational plan is to sit with the all your implementing partners within the county and plan to align their resources to the plan to be able to implement. Now, with my experience, the first thing is if the national plans and policies are done together, it provides the opportunity for donor partners to also be able to align their resources to your priority. So that's the first thing. Now, those resources, when it comes to the implementation level, those resources also need to align properly to the operational plans that you have in country. And jointly, you can monitor together. So in Liberia, what we did was to organize the Health Sector Coordination Committee, the HSCC, which is where the health sector policy decisions are made. It is normally chaired by the Minister of Health, co-chaired by the WHO rep. All the donor partners are present there, and they tend to give inputs into the strategy and the policy. So assign some of their technicians during the development process. And so when they are planning their support, they plan along those lines for us. And that works. Now, there are other examples. I did mention earlier which systems will continue to be weak. We've had situations where donor partners work with us to build financial management systems, for example. Currently, I'm at the University of Liberia at the College of Health Sciences. Before I got there in 2019, the College of Health Sciences had never managed $500 budget. Everything was highly centralized. But this is an institution where faculty members need to write research grants. They need to do research. They need to publish for their own professional group. The systems were not there. We were supported with donor funding by another US institutions to build the Office of Sponsored Research, to build the Office of Financial Management. We have a monitoring and evaluation system in place at the college. And we have a human resource office. We have a communication office. Those systems were not there. And so when people want to support you, they don't see those systems there. It becomes risky to put in their money. Since we started in 2019 to present, we've managed over $10 million, or we are managing over $10 million at the moment. It's because the systems are there. Of course, with the system currently, we are not independent yet. We are still working with the partners and growing the system until we can take on fully. But most of the work is done within our system, and they have high-level supervision for it. And I think that is a very good model. Because at the end of the day, when the international partner is not there, that system continues within the university. Thank you.
Thank you, Dr. Don. Do you think that NGOs cause mismanagement of resources as a whole or individuals with them? How can we ensure that resources go directly to the community leaders to aid local support and governance? Dr. Thiam, could you answer this one?
Okay, je pense qu'on voit beaucoup de cas de figure. On peut voir dans certains cas des ONG avoir des soucis de détournement, mais surtout dans les urgences. Mais on peut voir également, c'est surtout des cas parfois d'individus qui peuvent avoir. Mais ce n'est pas quelque chose qui est très, très courant. C'est des choses qui arrivent. Même au niveau de l'État, c'est des choses qui arrivent. Mais je pense que le grand problème, c'est qu'il faut qu'il y ait une distribution équitable, pas équitable, mais une distribution juste des ressources qui doivent aller au niveau de la communauté, au niveau des bénéficiaires. Et qu'il y ait un système. Et je pense que avoir des mécanismes de coordination, de suivi et de cartographie de l'action des ONG au niveau central, comme on l'a dit tout à l'heure, je pense que ça c'est important. Et avoir ce même système-là au niveau périphérique, c'est-à-dire au niveau du district, mais également peut-être au niveau de la chefferie. Ça également, c'est quelque chose qui doit se faire. Donc, je pense qu'à tous les niveaux, il doit y avoir ce système de redevabilité au niveau central, au niveau régional, au niveau district, mais également au niveau de la chefferie, pour pouvoir avoir ces mécanismes d'échange et de coordination qui permettent de suivre l'action de tout un chacun. Ça, pour moi, c'est important et ça doit être inclusif, c'est-à-dire toutes les parties prenantes doivent doivent prendre part à ces panels-là pour pouvoir suivre et évaluer l'action des ONG et des autres acteurs.
I thank you, Dr. Thiam. And And I see a question here for Paramount Chief Farley. How can donor agencies and international organizations deal directly with local leaders in managing situations like these? Do government policies allow for this?
Not directly. If it doesn't, there's a huge dysfunction in a lot of our post-colonial countries where things are very centralized in the seat of government. One workaround that you can develop, I'd already mentioned this before, but I'll say it again. Yes, it's a good thing to, if you have credible NGOs, I mean, really credible NGOs that are really accountable and who they can deal, yes, the central government will give them general authority to operate in the country, but they can deal directly with the traditional leaders who are best trusted by the communities to deliver. And so the model that I would suggest is large international organizations work with their local partners to deal directly with the traditional authorities. The government is already getting, although they always say it's not enough, the government is already getting a lot of money from places like the World Bank, the African Development Bank. They use our sovereign capacity to get funding for a lot of things, but a lot of that funding doesn't filter down to the communities. The best way to get it to filter down is to get a credible NGO and require them to deal directly with the traditional leaders who will guide them a lot better. And trust me, the communities will benefit a lot more because those traditional leaders are a lot more accountable to their communities than our national governments. Of course, the national governments still play a role in the overall coordination of registration of NGOs, but on a project-by-project basis, the most efficient way of impacting communities is through their traditional leaders, and through NGOs and through their traditional leaders.
All right. Thank you, Paramount Chief Farley. I see Dr. Don has two fingers up. So the floor is yours, Dr. Don.
Yes, I just want to compliment what he said. It is possible to support local governments directly. The same way I complained about donor partners falling on, not being very transparent, is the same thing that happens with the government and the central government holding on and not letting go to the local governments. Ideally, if you want that to happen, the local government system, the capacity needs to be built. The same systems you have at the central level needs to be in the local government office, and the different agencies well built within their local, take for instance, the counties within the county, which most of you will call district, and then they report to the local government office, who is headed by the superintendent. When you look at Liberia, you will realize that some of the services are decentralized to some extent, but one institution that will not decentralize is finance ministry. They tend to hold on and don't want to let go. And it's difficult to understand why, because the people who work at the local government level went to the same schools you went to. You
Yes.
people graduated from the same schools and you have the same degrees.
Yes.
It happens in the health sector the same way. In the health sector, you will see one program in immunization, for example. They will forever be training of trainers. They go to the local level, they train trainers. You expect that the people they train as trainers will scale down the training, but the people at the central will continue to go down to the county and the district to continue to do training. So as a result, the trainers they train can never have the opportunity to train. But it takes the government to make a serious decision to decentralize. Decentralize is easier to decentralize with all the other ministries, but they need to look at the finance ministry and see how they can decentralize finance ministry to support the local government, and all the other things will follow. That is very difficult to do in our setting.
Okay. Paramount Chief Farley, you had two fingers.
Just to buttress, I'm a professional engineer, over 4 decades. So my bent is more to see the world as it is, rather than to and say how will I get things done based on how the world is. As Dr. Dan said, no Ministry of Finance is going to decentralize, no matter what the World Bank or anybody else says. I can give lots of examples. I'm not even going to bother with that. But so the work around that is work with these donor partners can fund NGOs directly, but let them be reputable NGOs, and let the donor partners get feedback, monitoring systems that ensures that they have in fact dealt with the traditional leaders who are trusted by their communities. I think that there's no way government can stop that as long as the NGOs are working in the country. But to say that you're hoping, because the World Bank has been after our government forever to decentralize, and they even have a permanent decentralization secretariat, and nothing gets decentralized. So instead of following that, just go ahead and walk around it, walk through these international NGOs, get them to be credible, and work directly with those leaders. Nobody can stop that.
Thank you, Paramount Chief Farley. A next question from the audience says, looking into future outbreaks, what can technology, digital health, telemedicine, or connectivity be used to improve the handling of outbreaks? So Dr. Thiam, I think we can start with you.
C'est des outils importants et qui ont révolutionné les systèmes de santé. Et je pense que, par exemple, utiliser ces outils dans la surveillance, parce que ces outils sont déjà utilisés dans la surveillance, dans la détection précoce des épidémies, mais également dans la communication, pour faciliter la communication et le suivi des interventions entre le niveau central et le niveau périphérique. Donc, c'est des outils qui sont importants, qui peuvent nous permettre de faire des avancées significatives. Je vous parlais par exemple de la gestion des données, mais il faut qu'on comprenne que ce n'est pas ces outils-là qui vont changer peut-être certaines habitudes. Quand on parle il faut déjà, par exemple, si je prends la problématique de la qualité des données que nous collectons au niveau périphérique, ce n'est pas en mettant en place ces outils-là qu'on va régler le problème. Je pense qu'il y a un problème d'attitude, un problème de compétences qu'on va régler d'abord et un problème d'adhésion aux directives. Et ces outils-là vont nous permettre de régler les problèmes qui vont suivre. Donc, pour conclure, je pense que c'est des outils importants qui peuvent nous faire faire des avancées significatives dans la surveillance, dans la gestion des urgences sanitaires et dans le suivi de nos actions. Mais il est important que ces outils soient utilisés dans un contexte d'intégrité de ceux qui l'utilisent, d'engagement et de transparence pour permettre leur efficacité, pour permettre que ces outils-là puissent nous rendre les services que nous attendons d'eux.
One question, so we have only a 5-minute warning. How should external actors, whether they be bilateral or international NGOs, navigate the degrees of tension or separation between traditional government and central government? Typically, there is, for outsiders, a need to go through central government in order to get to the traditional government. which has both financial and programmatic implications. So for those of us who desire to work more closely with local communities and traditional leaders, what advice would you give for navigating this? So Paramount Chief Farley, we'll start with you.
You obviously need to register. Once you're registered as an NGO in the country, your program itself, you can develop over how you develop and implement your programs. But obviously, you have to register with some central agencies. That's why it's a good workaround. You're not required to implement all of your programs through the central government. In fact, most NGOs develop their own programs and deal directly with local governments. The problem is getting the dependable NGOs, because there's also a lot of malfeasance within NGOs. A lot of them spend a good percent of their funds just having meetings and meetings and meetings on end, which their personnel, their own staff usually attends, get a lot of per diems, and most of that is spent on that overhead rather than on actually programmatic things within the communities. But I'm sure the best NGOs will find a way of delivering most of the funding to the program itself. But I can assure you, just to build on something Dr. Tam had said, right at independence, there was a huge imbalance between the level of education and sophistication between those in central government and those in traditional institutions. Not anymore. Among Paramount Chiefs, you have medical doctors, you have lawyers. I'm a professional engineer. I'm a registered professional engineer. I've also done my master's in public administration and business administration. And a lot of times you actually have a lot more capable resources at the traditional governance level than at the central government level. So working through those NGOs, get the NGOs registered, but don't hesitate to work directly with the traditional leaders because we are getting more and more sophisticated.
Okay. Thank you, Paramount Chief Farley. And our last question will go to Dr. Don, as we only have 1 minute left. What would you have done differently to manage the crisis in terms of managing resource mobilization, distribution channels to get it to who needs it the most, and the problems of trust and credibility between citizens, NGOs, and government players? So the last minute is yours, Dr. Don.
Okay, for me, I will work in building government capacity. I will work with them in building the systems that are supposed to be built for them to be able to manage their own resources plus donor resources. An example is with the USAID funding that is being managed by the Ministry of Health, the fixed amount reimbursement agreements. This is an agreement between USAID and the Ministry of Health. The Ministry of Health from
Oh, okay. Well, unfortunately, because of the connectivity, and it is our final minute here, we do have to end. So I just want to say, thank you to our panelists for a fantastic discussion, and thank you all for joining us today. We also want to thank our sponsors, the Yale Institute for Global Health, the Walker Fund, and the Council on African Studies at the Macmillan Center at Yale. The session was recorded and will be posted on the Institutes for Global Health's Conversation Series playlist on YouTube. We look forward to seeing you at the next event of the Global Health Conversation Series. Thank you all and take care.
Thank you.
And thank you for providing the opportunity. I hope we were helpful.
It's been a pleasure.